NTB Dialogues featuring Dr. Urvashi Singh, Professor in charge of Tuberculosis Division of the Department of Microbiology, All India Institute of Medical Sciences, New Delhi. She is also the co-chair of Diagnostic Committee, National TB Elimination Program of India. She is a member of Diagnostic Committee, India TB Research Consortium, Indian Council of Medical Research, and she is a member of the ICMR Task Force on Genital Tuberculosis. So as you see, she wears so many hats on her head at the same time, so many caps. Welcome, Urvashi. And we are so happy to have you in our show today. And today we are concentrating on tuberculosis and just diagnosis basically of tuberculosis. So can you tell our listeners what are the tools currently available in India to diagnose TB?
Thank you, Shobhaji, Mr. Bobby, and the CNS for having me. I think it's very nice to be able to talk to you. Basically, um, our efforts here are to bring all the information regarding what all we are doing. And so the question that you asked was what all is available to us. So traditionally, what has been done for TB diagnosis is smear microscopy using, so we have different staining methods, but we do microscopy on the sputum sample or extrapulmonary samples. The issue with microscopy is it needs more bacteria to be detected. So with time, we have newer methods, but of course, smear followed by culture. This was the gold standard method. It picks up fewer number of bacteria. We can pick up even 100 TB bacteria per ml of sample by culture methods. And the culture methods earlier on were slow, but now we have culture methods which can pick it up faster. We use liquid culture medium and automated systems to pick up. Hence, these are good methods and continue to be the gold standards because the molecular methods, when they go faulty, we need to fall back on the culture-based phenotypic methods. So molecular methods are, today's times with COVID having taught us so much, it's nothing but a polymerase chain reaction-based, applications. So different systems have a real-time PCR-based, for example, there's closed systems like GeneXpert MTB-RIF, we have the TrueNAT system. Both use real-time PCR with a little modification here and there. The advantage of molecular systems, not only these two, these are, like I said, closed systems. India has another, ICMR has validated a system by MyLab. So there are several systems available to us. WHO has now approved some moderately complex systems by, by Becton Dickinson, by Abbott, by Roche, another fourth one by Heinz. These are automated systems which can detect TB as well as drug resistance. Now, in the GeneXpert and TrueNAT systems, as of now, till now we were only doing rifampicin resistance detection. Though today's times we also need resistance to other drugs because we have regimen designed differently. So we are coming up with newer systems which tell us resistance to extended drugs, rifampicin, excuse me, INH. Sorry. And a few second line drugs as well, which are required for treatment of MDR-TB. So there is, ample support from technical backup, and we use it day in and day out to help a patient's diagnosis.
Now, the WHO has called upon governments to replace microscopy completely with molecular tests.
Yeah.
So, can you just explain a little bit more that how does molecular testing compare to microscopy in terms of early and accurate TB diagnosis?
Yeah, so like I said, smear microscopy is an old test. And the flaw with smear microscopy is only that it needs about 10 to the power 3, that is 1,000 to 10,000 bacteria per mil of the sample, per milliliter of the sample. Now, often the disease can be in such a stage that these many number of bacteria are not present in the sample we collect. So smear microscopy loses in its sensitivity, analytical sensitivity. So what we call as limit of detection of smear microscopy is not as good, while molecular methods pick up anywhere, close to a range of 20 bacteria to about 100 bacteria per milliliter of sample. That way, we can pick up more patients, and the loss to diagnosis is much less. So these are much more sensitive, better limit of detection methods. And like I said, with advancing technology, we have been able to get the molecular methods to the peripheral centers as well. We're working towards it, and India also has acquired several machines placed at peripheral centers for early diagnosis.
Yes.
However, I beg to differ when we talk about replacing smear microscopy. Smear microscopy does serve a good purpose. As far as pulmonary tuberculosis is concerned, it is specifically picking a certain number of patients. It is not really losing a lot as far as pulmonary TB is concerned. So, in places where we are not able to equip with molecular method, there are several developing countries where peripheral centers may not get a molecular method soon enough. Till such time, we can ensure the molecular method availability at the peripheral centers. Till such time, we can ensure that electricity, for example, in our remote villages, because most of these molecular methods run on a system which needs electricity. So till we
Yes.
are well equipped to replace microscopy, we should not really push it too hard. We should work on enabling our peripheral centers with molecular methods to enable them to diagnose early. Also, there's one more catch. Most of the molecular methods that are being used today are not picking non-tubercular mycobacteria. So in tropical countries, non-tubercular mycobacteria tend to infect post TB. So it comes in as a patient who's been treated for tuberculosis, has healed, may now get a non-tubercular mycobacterial infection. So unless the molecular methods we are offering are also poised to detect non-tubercular mycobacteria, till such time we'll have to depend. So it's a work in progress. Everybody is working hard. Let's not talk of replacement just today. Also about follow-up. So a patient is on treatment. So three factors, like I said, where molecular cannot reach, microscopy still works. Non-tubercular mycobacteria, till we can use molecular methods to tell us non-tubercular mycobacteria, they are important pathogens. They can also lead to mortality. Most often creep in after TB is treated. Thirdly, like I said, molecular methods are picking DNA in a patient, DNA of mycobacterium tuberculosis. Now, the DNA will be present even when the mycobacterium respond to treatment. That is, they are dead because the patient is being treated. Hence, molecular methods detecting DNA cannot pick up patients who are responding to treatment. In fact, the guideline is such, the WHO recommends that a patient who's been treated within the last 5 years should not be diagnosed on GeneXpert alone or TrueNat alone, because the DNA may be present even after treatment. So prognostication, as we call it, prognosticating a patient, DNA-based or molecular methods which are using DNA as a molecule are not really, useful. So there we can use microscopy. The moment the patient starts responding, the smear microscopy tends to become negative, and that tells us that the patient is responding to the treatment.
Okay, is there is this is a question which sometimes comes to me. Is there more chance of a human error being involved in microscopy while doing
Human
microscopy?
errors can be involved in any test.
Mm-hmm.
In microscopy, we have, so the test per se is very simple to perform, and the microscopist will look for specific bacteria. So it's very unlikely that it will be
Okay.
false positively reported. And we
Okay.
have, better methods, like we have the fluorescent staining method, where again the people are trained to do microscopy. But this applies to molecular methods also. The training of the staff has to be there. They have to be able to process carefully. They are trained to not carry over contaminating DNA from an earlier positive sample to a new negative sample. So training is part of the process, and we cannot really say one method needs more training than the other. They both have, the training needs to be done. So an untrained person is never put on the job. It's always
Okay.
a trained person who takes care. Yeah.
How important is it to do drug sensitivity test, or what we call DST, before initiating TB treatment? Should it be mandatory? And of course, at least I generally hear about only rifampicin resistance being tested, if at all. Is that enough?
Yeah, that's
So,
a very good question. So let me
mm,
come to the first part of your question.
yes. Mm,
That is it important? It is
mm,
very important because if we are treating, so in case we do not know that the patient is infected with a rifampicin resistant or what we call as MDR-TB,
yeah.
because those who are resistant to rifampicin are most often resistant to INH as well.
Mm,
In 96% of the cases, rifampicin resistance comes in with INH resistance also. And the first line treatment that we use is based on rifampicin, INH, ethambutol,
mm,
and pyrazinamide. Now,
mm,
if we do not know that a patient has rifampicin resistant TB, we
mm,
will be using the first line treatment.
mm,
And that will only worsen the disease. It will, in fact, enhance the replication of the MDR organism. It is very important to know that the patient has resistance to the drugs that we are using. You know, the simile can be drawn with any other bacteria. We
mm,
always
yes.
treat, say, even if it is a Staphylococcus infection or a
Yeah.
UTI because of Escherichia coli, we treat based on the drug sensitivity profile. If we are using a drug which will not work, we are making the disease more complicated, more complex, difficult to treat.
Mm,
And in a disease like TB, we do not treat in time. The patient, we can lose the patient.
mm,
And worst of all, TB is a disease that is spread through the air. So the droplets, while a person speaks, get airborne. The droplets, once airborne, will dry and lose their water content. What becomes of the droplets is droplet nuclei. Now, the droplet nuclei are very light in weight and very small in size. So, being light in weight, they flow with air currents.
mm,
Flowing with air currents, and they can impinge upon. So if I'm breathing in the air, which is rich in droplet nuclei, the nuclei are smaller than 5 microns. They'll go and impinge in my, distal part of the pulmonary, the respiratory tract, and can cause infection. So the bottom line I'm trying to come back to is, it is a disease transmitted through droplet nuclei, through air currents, and if a patient is not treated aptly and completely. So the right
yes.
regimen has to be prescribed. A complete regimen has to be ensured. The patient should be treated with a complete duration of the regimen.
Yeah.
If not, the patient may continue to shed bacteria and putting his community at risk at large. So all these factors are very important. We need to curtail transmission. First, we need to cure the patient in concern. We should give the best treatment possible, and we need to take care that he stops the transmitting. So we need to break these chains of transmission as early as possible. You said only rifampicin. I'm totally in agreement with you. We were only doing rifampicin because we were trying to diagnose MDR-TB. And like I said, rifampicin resistance in 96% also talks about INH resistance. Hence, we are treating MDR-TB. So the treatment for MDR-TB is different, clearly defined, available with National TB Elimination Program. It works very well. But when we are designing the MDR TB regimen, so we try to give the best possible. There's a lot of effort by the program, but our burden of TB is high. So the MDR TB regimen constitutes of 7 different drugs and sometimes more. The shorter oral MDR regimen has 7 drugs. The longer regimen, which we are slowly trying to move back to the shorter regimen, because compliance with shorter regimen is always better. The patient gets an intensive treatment and responds early, 9 months treatment, and he's okay. So the drugs that are used during the MDR regimen, again, there can be resistance to those drugs as well. So unless we know at the baseline whether the regimen, the treatment regimen we are prescribing to the patient is the optimal regimen,
Mm,
we may not be doing justice to the patient, and the patient may not respond, may have issues, may have prolongation of disease, and sometimes fail to the treatment we are giving. So it would be ideal that we know the susceptibility profile to all the drugs we plan to put in the DR regimen. So, and like I said, a lot of effort is going in that direction. We have phenotypic methods which are able to do susceptibility testing to all the drugs we are using. But then, even despite using the liquid culture system, we have a loss in time in the sense the liquid culture will take about a week to 2 weeks in, first to come as positive. And then we do the DST for this particular strain, which would entail another week to 10 days. So we may lose about 2 to 3 weeks. The molecular methods are now coming up. Like I said, even the newer machines, or Gene Expert has come up with an XDR cartridge, though the nomenclature is slightly old. It follows the old XDR
Yes.
definition. The current definition is different. The TrueNAT has designed chips for fluoroquinolones, bedaquiline, and they also have chips for non-tubercular mycobacteria for INH. So INH and fluoroquinolone are two drugs we must know before we can put a patient on shorter oral drug regimen. So you very rightly pointed out, it will be ideal to have complete DST profile to all the drugs we plan to use in our regimen.
Okay, so you mentioned, and I agree that you said we are moving slowly to the shorter regimens. Why are we moving slowly to the shorter regimens? Why,
So
why not? Yes.
So I didn't really mean slowly. I actually, probably it must have come out that way. I meant shorter oral drug regimen will be the best option. But
Yeah.
then in patients in whom we cannot use drugs like INH because there is resistance to INH, especially high dose INH. In patients where there is fluoroquinolone resistance, we are not able to use shorter oral drug regimen because these are essential components of the 7 drugs which we use for shorter oral regimen. So we are kind of forced to use other than the shorter oral regimen. Now here, what is important is the relevance of restricting over-the-counter availability of these drugs and misuse of drugs which are reserved for using in MDR-TB. That is something that needs to be driven aggressively, if I may kindly use the word, because fluoroquinolone resistance crops in because of prior usage by the patient or usage in the community. And fluoroquinolones are drugs which are very effective in a lot of other diseases. Hence, they are prescribed in several other diseases. Same is the
Like,
story.
I'm interrupting here. Sorry.
Yeah.
Like diseases like?
So, fluoroquinolones are, in fact, should not be, but are also used in pulmonary infections. Something like even people, let me not, so they even use it for something as simple as a pharyngitis, a laryngitis. You see, in a pneumonia, you would still think it is a serious infection and the patient may get complicated if you're using such a drug. For urinary tract infections, so these are being rampantly prescribed, and ideally, we should ensure that the drugs we have in such difficult to treat diseases, and these are some drugs which are important for treating an MDR-TB, for example. We should try and restrict certain groups of drugs for, the diseases with sinister outcomes. The mortality in these diseases can be very high, and we have to depend on important drugs.
All right. So, in fact, I think we need to sort of strengthen our basic systems
Absolutely.
so that we are able to test for these resistances and then put them on a shorter course. Because, like to a lay person like me, I would like we and even the community goes all out to have the shorter regimen because that will save a lot of trouble. It will be
Absolutely.
more patient friendly. But as you said, that you need to test the patient for resistance against those drugs which are being used in the shorter regimens.
Yeah, yeah,
So,
right.
so that we
So
have,
I think
yes.
there's a lot of effort from
Mm,
all over the country
mm,
to reduce over-the-counter availability of all antibiotics for that matter. There's a lot of
yes.
push for
Mm,
AMR that, only a doctor's prescription should allow a
yes.
chemist to dispense
Yes.
the drug. So there is a lot of effort, but like you said, more needs to be done to ensure that we are able to give the best to patients who need the best. So
Yeah.
yeah.
Yes, because the general scenario is, Urvashi, that for a common cold or some fever, like
Yeah,
persons like us, we just go buy some antibiotic. And
absolutely.
I keep on telling my friends and my acquaintances that why are you going for an antibiotic? If it is not a bacterial infection, how is that going to help you? But that is as because it is sold over the counter.
That's right. Yes.
Uh, and
And despite
yes,
the fact that it is written Schedule H drug, but then the ease of availability.
Yes.
You see, the ease of availability is positive in some ways, that
Yes, yes.
in a peripheral area where a patient is unable to reach a doctor, or though of course that is also changing with time. There is ample effort to reduce that kind of an issue, that availability of a medical professional to guide a patient. So the benefit is there, where easy availability could help a patient, but then the rampant use and the
Yes,
rampant misuse
yes,
should be stopped.
right.
Otherwise we'll be left without any good drug.
Yes, exactly.
Bacteria are very smart. The other day I was teaching the undergraduates about the relevance of bacterial resistance. The bacteria has to survive,
Yes.
and it is smart. It will find ways of generating resistance. And the more the availability of the antibiotic to the bacterium, the smarter it is. In fact, the dumping of extra antibiotics into landfills makes the antibiotic available in sewage, in water, bodies. And the bacteria are smart. They will generate resistance the moment they have antibiotic available to them in sewages and in water bodies. And so even those things need to be taken care of
Right.
at the public health level.
Yes, exactly. You are so very right there, Urvashi. And in fact, I had a question for you later on about how to curb antimicrobial resistance, and you have spoken some right here about it. Uh, Now, when we are talking of peripheral systems, the existing diagnostic tests, we have the best of them.
Yeah,
I think TrueNat is one step ahead in the sense that it is battery operated. Can be, I have seen it. It can be carried in a small suitcase and
that's right.
just on. So maybe that needs to be promoted more in places where we find more TB, where say a lab or a tertiary care or even a secondary state hospital is not easily available to the
Yeah,
people.
yeah.
So I think
So yeah,
mm,
our effort from the beginning has
mm,
been
mm,
to enable systems which can reach the patient.
right. Mm,
In
mm,
fact, a lot of drive for with the program, along with the other agencies supporting, we are trying to get vans which will be equipped with X-ray and a
mm,
system, whether it is TrueNat or a Gene Expert system. But like you rightly pointed out, a battery-supported system will
mm,
overcome the need for electricity supplies to be there.
exactly.
So there is a lot of push, but like I said,
Mm,
the issues that we do face is one, of course, the large population. Two, the high endemicity in our country.
mm,
And three is hitch on the part of the patient
mm,
to not really reach the system.
mm,
So those are things that we need to alter. We need to reach the patient, of course, but we also need to provide enough health education. The patient should be aware that he will be taken care of once he reaches the system. You know, the patients tend to ignore their complaints. So if I refer to the National TB Prevalence Survey, which was conducted by
yes,
ICMR and NIRT
mm,
and published in 2022, brought this out very beautifully, that more than 60% patients ignored their systems. Ignore, they did
the
not
sim.
think that a cough and cold, and so this is something that we must acquaint our population, that TB will present in a very it will present as low grade fever, evening rise of fever. So the patient has enough energy in the morning. The patient will like to work and go to work, and will possibly think it is a weakness kind of a thing. They would describe their cough, their low grade fever, and their protracted cough to maybe some viral illness, or they would ignore it, thinking that their work will be compromised if they go to a hospital or to a medical center for care. That is the attitude we need to change. That is the attitude we need to tell them to come to a medical center, be it, so the dot centers are ample in number. Here I would bring in the problem of stigma with TB. So a lot of our community thinks if they're diagnosed with tuberculosis, they'll be stigmatized, that their colleagues or their family would probably not treat them well once they. But it is important for them to understand, earlier the diagnosis is made, the better the treatment opportunity, the better the treatment would be. The treatment will ensure complete cure.
Yes.
If there's a delay in approaching the hospital or a medical center, the delay can lead to, of course, the spread of the disease within the person. So the entries, like I said in the beginning, it's always droplet nuclei which we are inhaling in the air, which may be coming from another patient who may have shed it unknowingly.
Yeah.
So these patients who are not reaching the system, do not know that they have TB, are not getting treated for TB, and they're continuing to disseminate the disease.
Right.
So a patient has to be more vocal about his symptoms, not brush it under the carpet that this could be just a cough following a protracted cough, low grade fever, symptoms of tiredness, and so on and so forth should always be brought to the notice of a medical person, medical care specialist, anybody. They should just reach the system, get themselves tested. What is more important is people who are old age, people who have comorbidities like diabetes. And again, coming back to prevalence survey, what they showed was patients who had smoking history, who had alcoholic history. So these were few groups where tuberculosis was found in more numbers, and they had not, they did not seek medical guidance or diagnosis. So it is ideal for them to get themselves screened at least once in a year. One group that I did not mention till now and is a very important group is patients who are undernourished. So,
Oh, yes. Oh,
undernourishment
yes.
was associated in a big way in the prevalence survey. What we found was a lot of patients who were low BMI had tuberculosis. So, it would be ideal for them to get a screening, and of course, for the system to support them. So a lot of TB patients we find are having low BMI, and the government has started the direct benefit transfer, and all that is taken care of. There are several programs with the National TB Elimination Program where they're trying to support the patients with nutrition as well. So there's a big drive towards that, but people should be aware if they are the low BMI is there and has been for a long time, possibly they can get themselves evaluated for TB. And there is no shame in coming to the system.
Yeah.
And like I said repeatedly, not to ignore their symptoms.
Yes. Urvashi, on the ground, I have found, like I have cough, say, for prolonged period of time, or I have low grade fever.
Yeah.
I would go to the nearest medical clinic. I have gone to some medical clinic.
Right.
But unless the physician says you go for a TB test, the physician may give some medicines and that may continue. So I have seen in many cases from personal experience that the person has approached whatever health facility was there closest to that person's house,
Yeah.
but still there is a long gap between diagnosis and his or her approaching the system. So
Absolutely, I agree with you. There may be, there's sometimes error at the other end as well, but
yes,
nevertheless, possibly if the symptoms continue, I would
yes,
say the patient should not ignore
yes,
himself.
yes,
For his own sake, the sake of his own family, his
mm,
contacts within the family, workplace, the older people, the parents or older people living with the patient. So it's like I said, these are the people who are at higher risk.
yeah,
The immediate contacts, the older people in contact. So if the symptoms continue and the symptoms do not resolve after the physician has prescribed a
right.
treatment, please go back. Ask for,
Okay.
maybe an X-ray, maybe a sputum examination. And like I said, if you compare the health systems abroad or in other countries, our country offers free treatment to our patients,
Okay.
unless it is in a private sector for a surgical this thing or something.
Mm.
So our government health system works in a very steady fashion, and very committed physicians. So I would only say that the patient should approach the system again. Do not lose your faith in the system, because everybody here is very committed to help each and every patient. And in fact, there is an effort at active case finding. So a lot of us are teaming up and enabling active case finding in slum areas. There have been studies which ICMR did in tribal areas, and they found so many TB patients who were not even coming to the system. These patients were then linked to the National TB Elimination Program, to the dot centers. They were followed up, they were treated completely. So there is an effort for doing active case finding. We are not really waiting for the patient to come,
Yes.
but it would be ideal that the patient should come so that the patient is not missed. Now, active case findings is being done in several pockets, slums, old age homes,
Yes.
and these ren baseras, and
Yes.
night shelters.
Yes.
But then it may not be practically possible for the system to cover all these centers. So, be it poor, be it rich, everybody should seek healthcare, and the health system is fully equipped to help out. And like I said, we're reaching the peripheral health centers. So the gene expert systems were bought more than 10 years ago and disseminated throughout the country. Then TrueNet systems were bought. So the National TB Elimination Program is trying to equip
Right.
the peripheral centers as best as they can. But
Right.
of course, if the patient can reach the system, all the more better.
Right, right. That's a good message for for the people. Uh, Urvashi, all these molecular tests and the diagnostic tools we have talked about, they are based on sputum. That is, the sputum is tested. Now, how does the quality of the sputum affect the test results? And some people find it difficult to produce sputum.
Absolutely.
So, are there any non-sputum based tests in the offing?
Yeah.
Uh,
So let me first offer a
okay.
little correction there.
Uh,
So though in pulmonary TB we will ask for sputum
yes,
to be
yes.
tested, but in a tertiary
Uh,
care center like ours, we are testing all kinds of extrapulmonary
yes.
samples. Now, all kinds of extrapulmonary samples would include lymph node aspirates.
Mm,
So, a patient who has a lymph node TB, we will just do aspiration from the lymph node. We will test that with molecular methods and culture and microscopy. Like I said, we test, anything and everything. We test pleural fluid. We test ascitic
mm,
fluid. We test joint fluids. We test in female genital TB. We also take endometrial aspirate from a patient who's suspected of, who has presumptive female genital TB. We will take endometrial aspirate and test that. So all these samples are collected, processed, tested. So we have all our techniques work on all these samples. So CSF is a very good sample. And let me, take this opportunity to say, which I did not really elaborate earlier, a person who does not get treated in time for pulmonary TB. Like I said, the only entry point in a body is through the air.
mm,
Now, once a pulmonary TB sets in and the patient, say, tends to ignore it, maybe it was too short lived, this TB either can be controlled by the immune system in the body or may even lead to disseminated tuberculosis. Now,
okay.
dissemination of TB can involve any organ of the
Mm,
body, practically any organ of the body. So if the TB goes to the central nervous system, this is one organ or one area where treatment can be very difficult or prolonged, because the antitubercular drugs may not reach in adequate amount
mm,
in the CSF.
mm,
And we have a very high mortality. We have a mortality to the tune of 30% in the case of TB meningitis.
mm, mm,
So the message to the community should be, come to the system early. Do not let the disease get florid. We don't want to lose these patients. And this is a completely treatable disease, as against a few other diseases where complete treatment is not possible. We can completely treat them, but if the disease gets too florid, becomes disseminated, involves the CNS, we can have mortality due to tuberculosis. So, coming back to what you asked, that the molecular methods can detect. So, we are equipped to detect all kinds of TB, only rare forms where it is difficult to get a sample from. For example, there's a deep-seated infection and we can't reach it. For example, there's something in the spine which is difficult to tap the sample. Or sometimes, even if, for example, we're taking an aspirate from a lymph node and we're not getting an adequate yield, adequate sample, a joint fluid, we may not always get a sample which is representative of the pathology that is there, which, as is understandable, is a difficult to reach site. We have certain techniques, certain tests available to us now. So, for example, we have the antigen tests. As is used, even in dengue, we use the NS1 antigen test for diagnosis. So for TB, we have something called as lipoarabinomannan, which is a part of the cell wall of the TB bacillus. And this is present in practically all samples in the body. It can be detected in sputum, it can be detected in serum, it can be detected in urine, it can be detected in CSF. Now, the beauty of this antigen is it gets, so once the bacterium is broken down by our immune system, by our macrophages, the antigen of the bacterium can be filtered out. It's a small antigen, so it can be filtered out and is in fact concentrated in the urine. So urine is a very good sample, especially in, so a lot of published work you will see is available in people living with HIV.
Yes, yes.
Those who get tuberculosis disease, we can use urine LAMP detection, which is a lateral flow assay, very easy to do, can be done at the periphery also. And in PLHIV, we can diagnose TB with LAMP. LAMP is a very highly specific test. The specificity is very high. So if it gives a positive, it is definite TB. If it gives a negative, we can, further do other tests because the sensitivity may not be very nice, very high. Sensitivity is in the tune of 60 to 70%, while specificity is more than 90-95%. So this is one antigen test. And let me also share with you, a lot of literature came in between the year 2013 onwards from the Western world in PLHIV with TB. And we were probably the first group who tested it in pediatric population and small children. We did the study in the year 16 to 19, and we published in 2019 that this test, the urine LAMP test, was in fact more sensitive in children with tuberculosis than gene expert. Gene expert in children can have issues. I'll come to that shortly. The message that I'm trying to give is the LAMP test, the urine LAMP test, which is being made by two makers now. The Abbott has taken over the Earlier LAMP, and the Fuji LAMP is another very sensitive method. And we have some third generation tests coming up. It can pick up with high specificity. So a positive is definitely TB. A negative needs to be investigated further if clinical suspicion of TB is there. So coming back to my point, in children with TB can have two kinds of presentation. Either they will have the lung parenchyma involvement, where detecting TB from their respiratory samples, where we can take gastric aspirates. And you earlier asked what other than sputums, we can also have induced sputum. We nebulize the child and we use inducing of sputum, and also in adult patients who are not able to bring out sputum on their own, we induce the sputum using nebulizing or even steam inhalation at home can facilitate bringing out a sputum. So patients, children who have parenchyma, lung parenchyma is the lung tissue involvement, will be able to, bring out sputum, or during when we perform a gastric aspirate, we'll have a sample of the sputum they ingested. We take it out from the stomach. These can be good samples for a gene expert to detect TB. But say in case this child who, so like I'm repeatedly saying, he inhaled, got parenchymal TB, parenchymal involvement, but the immune system tends to repair. So the parenchymal involvement got repaired, and the child still has TB in his mediastinal lymph nodes. In such children, we give it the term intrathoracic TB to cover both parenchymal and mediastinal TB. The sputum or the gastric aspirate may not be detected by gene expert. So the gene expert or TrueNat or even culture method, which I say is the gold standard, may not be able to pick up TB in patients where the lesion has been walled off. Here, tests where antigen detection like LAMP in the urine can serve as a very useful test.
Okay. So lamb should not be used more, because sputum always, even in the general public, but lamb is generally used for children, from what I have read, and for HIV, people living with HIV.
Yeah.
It is
So,
not.
yeah. So you see this when this test came up, it was initially used in PLHIV. So
Yes.
recommendations came for PLHIV because they actually showed the
Mm,
shortening of diagnosis by the use of LAM, in fact,
mm,
reduced the mortality in PLHIV with TB.
mm.
Now, as evidence keeps coming in, people tend to use it, or once recommendations come in, so first the evidence has to come in,
Yes.
then the recommendations have to come in, then only people will use. So
Mm,
we have some ongoing work in extrapulmonary TB as well.
mm,
Like I said, we did a study recently. One of my MD students concluded that we tested LAM in CSF in TB meningitis, and we in parallel did LAM in urine in these patients. So urine LAM was in fact better than
mm.
CSF LAM
Okay.
because it tends to get filtered out or whatever.
Mm, mm,
So we have been able to use urine LAM in patients who have TB meningitis. And like I'm repeatedly saying, specificity is very high. Sensitivity may
Repeat.
not be up to the mark. We may miss a few patients, but then if our doubt or our this thing of presumptive TB is clinical suspicion of presumptive TB is still there, we can still continue to investigate the patient till we are sure of the diagnosis. So it is a good test. Now, like I said, as evidence comes in, more and more people use it. We have shown evidence of extrapulmonary TB. We've also done in lymph node TB. Lab is picking the patients, so this was compared to gold standard diagnosis. It was doing very well.
Okay. Great.
But for now, we do not have the availability. I'm sorry. Yeah, it's not
Mm,
really available.
mhm,
Fuji Lab had brought it in, but they're probably increasing the number of
yes.
factories, still improvising. Abbott
Mhm,
is also still improvising, and we have some. So it is, I think, undergoing BCGI approval for use in PLHIV, though the
okay.
NACO has recommended it. So we hope to have them soon. And like I said, the third generation lab will also be available soon. So we should be able to put them to use. Yes.
All right. You are part of genital TB ICMR task force. Is genital TB less understood as compared to TB of other parts of the body? Means not pulmonary, but even when we are talking of extrapulmonary TB in our country. And how difficult is it to detect genital TB or other forms of extrapulmonary TB?
So we've had a lot of studies. In fact, I would say for 20 years, different, so gynecologists have been working with
Yes.
different groups, very esteemed gynecologists, Dr. Kriplani,
Mhm.
Dr. Neena Malhotra, Dr. J.V. Sharma, and, several groups we've been working. And what we've been trying to really do is, so coming back to your first part of the question, is it difficult to diagnose as compared to other extrapulmonary disease,
Mm,
extrapulmonary TB?
mm,
Now, in other extrapulmonary TB, the patient would be having some symptoms or would have a florid presentation. In female genital TB, the patient will probably only come to us when the patient is not conceiving. So,
yes.
like I
Correct.
said, the entry for the TB bacilli, it gained entry through the respiratory
Mm,
tract, had a pathology in the lung, which at that point was possibly ignored, and the TB bacilli spread, and female genital area is one place where it will go and possibly not cause a florid disease. Sometimes the
mm,
patients do come with symptoms other than infertility, but most often we diagnose patients who come to us with infertility.
yeah, right.
Other
Yes.
times the patient could come with issues like their problem with the menstruation and so on and so forth, loss of weight, and similarly gynecological problems. What we do is we take an endometrial aspirate or an endometrial biopsy, and we diagnose using our culture methods, our molecular methods. We detect TB bacilli and we prescribe treatment. And most of these patients with infertility, unless they are florid and there is disease has led to fibrosis, and the fallopian tubes are now closed because of fibrosis. Unless the disease has progressed, these patients will respond and they conceive
Mm,
and they have children, and so the
mm,
earlier they come to the system, it
mm.
is always better. And like I'm saying, healthcare here does not cost them much. They reach a government hospital, they get the best of care, and yeah, we're able to help them.
All right. So, as of now, what are the best tests to diagnose extrapulmonary TB early? You have mentioned the LAM test that it has helped you.
So that's a non-invasive method for
That's on.
detection from urine.
Mm,
But
mm,
like I said, sensitivity is one issue
mm,
where we may not be able to utilize
mm,
its,
mm,
its high specificity in all samples. So
mm,
we are primarily depending on molecular methods. So
mm,
molecular methods,
mm,
a lot of groups have published, and we have published in 2013. WHO gave a recommendation for use of gene expert in extrapulmonary samples, especially CSF. The sensitivity of gene expert in other extrapulmonary samples can sometimes be less.
mm,
Again, the reason, so molecular methods are not really um, foolproof, if I
mm,
may use that word.
mm, mm,
There
mm,
can be issues with inhibitors in extrapulmonary samples. So if we're using a pleural fluid, for example, now pleural fluid is a sample which is very highly rich in protein, which can
mm,
cause inhibition of the PCR. Now, PCR is a molecular test which is dependent on
mm,
enzymes.
mm,
Enzymes amplify the DNA of
mm,
microbial tuberculosis. Now, if these enzymes are inhibited because of inhibitors, so-called inhibitors, like I said, the clotting cycle, the coagulation factors, high protein, hemoglobin in a blood, in a sample when during collection it can have too much of blood. These things can cause inhibition of all molecular tests, not gene expert alone.
mm,
So, though WHO gave a recommendation in 2013, we were part of the evidence that time, and subsequently we've also worked on TrueNet in extrapulmonary samples, and it worked beautifully, as well as gene expert. So all the molecular methods do come to our aid.
mm,
And like I said, when we miss using any of these methods and we continue to have the doubt, we depend on other methods. Like culture is very good, but again, extrapulmonary samples have possibacillary disease. So the number of bacteria are
mm,
fewer in
mm.
extrapulmonary disease. So sometimes culture may also act tricky. We may not always be able to pick it up. But yes, we do try to use all of these, and they're uh, very, very helpful techniques.
All right. I just read the WHO has just published recommendations on the use of what they call targeted next generation sequencing tests for rapid detection of drug resistance to the new anti-TB drugs. Are these tests based on, are they the same as genome sequencing
They're all,
tests?
yeah.
Mm,
So, you see, when we're talking of drug resistance to any antibiotic,
mm,
and here, since we're only talking about anti-tubercular drugs, we
mm,
have
mm,
agents which we use as the first-line drugs. We have agents which we use as the second-line drugs.
mm, mm,
Now, resistance to these, like I said, the bacteria is very smart. What it does is it brings in one single nucleotide polymorphism. We call it a mutation, SNP or a mutation,
yes.
and changes the target where the drug is going to go and bind.
Mm,
So the drug is unable to bind, and there is resistance that creeps in.
mm,
So why I bring this here is, if we detect this mutation, which is responsible for drug resistance, we can very easily say that this particular drug will not work. There is resistance to this drug. Now, how do we detect these mutations? There are several methods. Like we were detecting rifampicin and INH by Gene Expert or TrueNet. They also use the same principle. They use
mm,
real-time PCR to detect
mm,
these mutations, individual
mm,
mutations which are known to be responsible for drug resistance to these particular drugs.
mm,
Now, with the available, enhancement or increased knowledge, improved technology, we are able to also do whole genome sequencing,
mm, mm,
and the whole genome sequencing will tell us the complete genome of an organism.
mm,
We do something, to help us detect drug resistance. We do something called as targeted NGS,
mm, mm,
targeted next generation sequencing,
mm,
where,
mm,
just to simplify, we are amplifying the genes where known mutations to the drugs are present. We amplify those genes by PCR, and we sequence these genes. We're not sequencing the whole genome like we do in whole genome sequencing. We're doing in target next generation sequencing only targeted amplification of genes where mutations to drug resistance are present. We amplify these genes and we look for these mutations either by sequencing, or short of that, like I said, the even the closed systems are coming up. Gene Expert has come up with Gene Expert XTR. WHO has recommended, like I said, Abbott,
mm.
Roche, Heinz,
Yeah.
and Becton Dickinson system, which are getting equipped to look at the second line drug resistance as well. For now, they're offering INH and fluoroquinolone, but they will soon be able. Targeted NGS tells us we can look at bedaquiline mutation, we can look at delaminid resistant, linezolid resistant, all the drugs we use for treating tuberculosis. So that is how targeted NGS can help us. And we have a catalog of mutations by WHO. In India, NIRT has come out with a catalog of mutations prevalent in India. And we, as long back as 2003, 2004, we sequenced countrywide isolates and shared the mutations prevalent throughout the country. Northern region had different isolates, genotypes, different genotypes of TB, southern had different. So there is ample data available to tell us which mutations will be responsible for drug resistance. We just need to equip our countrywide to be able to use the targeted NGS better.
Right, right. So do you see this targeted or whole genome sequencing as the future of DST?
Absolutely. So yeah, so this was so we have been working on so first I will answer the question directly and then take it to how the country is getting equipped. So the like I said, we pick up these targets because we know these targets will tell us this particular drug is useless. We should not be using in the treatment regimen. So it is something which can, once scaled up and available to each and every patient for the country, can actually help us design what we call as individualized treatment for each patient, or tailor-made treatment, which is the ideal. Like I was giving a simile of other bacteria earlier. So as early as 2013, we started working on getting sequencers for the country. So in 2018, the process went on and we were able to procure sequencing systems for 6 sites, the national reference laboratories in the country. They are equipped and they are capable of doing it. We need to further simplify with COVID teaching us so many lessons during, 19 to 23. There is a lot more molecular dependence or, confidence on molecular methods. We should be able to equip countrywide with this NGS method. So we'll be able to design.
You have been involved with TB vaccine research too.
Yeah.
What does the future pipeline look like for
Yeah.
a new safe and effective TB vaccine?
Yeah.
And are there any clinical studies going on in India also?
Yes.
For a TB?
So yeah, so vaccine is one short way of ensuring that either the infection does not occur, or the disease does not occur, or relapse does not occur. So we have vaccines
Yes.
which take care of prevention of infection vaccine, prevention of disease vaccine, prevention of relapse vaccines. So ideal would be a vaccine which gives us prevention of infection. Now we have the BCG vaccine, which is recommended for all children at 0 day, and very rightly so, because this vaccine will safeguard against disseminated TB in small children in a high endemicity country like ours, and in protection against meningeal TB. So sinister TB, it does protect against. The issue is that the protection wanes off by the time of adolescence or adulthood. So BCG vaccine continues to give the protection, and we've seen that. And let me first complete about the BCG vaccine. So we had some large trials globally. And incidentally, the trial which was done in Chingalput in India, there was a supposed trial in the north as well around that time, which did not happen. But the Chingalput trial did not report protection when the reports came out. And the absence of protection was ascribed to prior exposure to non-tubercular mycobacteria, which, if you remember, I mentioned in the beginning. Yes. All the tropical and the temperate zones tend to have non-tubercular mycobacteria. So there were several reasons given why BCG was not very highly protective, but we continue to use the BCG, like I said, in our children. It protects against, disease that would kill, neurological, disseminated, and so on. Now, recently, there was a relook at the Chingalput data, and what the NIRT published was there was 36% protection by BCG. So we have ample evidence to continue to use BCG till such time we have a better vaccine available. Then there was an article in NEJM, New England Journal of Medicine, the topmost quoted journal, where they did a study in South Africa. They used 2 vaccines, and there also BCG showed 45.4% protection. Now, the bottom line I'm coming to is a lot of countries were using BCG revaccination as well. So BCG vaccine is given at the baseline at the 0 day, and the children or the adolescents were given BCG revaccination as well. Especially in the Europe, several countries were doing this. So our country has now taken this up, BCG revaccination in certain districts, and this is one trial which is going on.
Mhm.
We initiated a trial in the year 2018 where we used a vaccine manufactured in India, which was based on Mycobacterium indicus prani, or the MIP vaccine.
Mhm.
And we also had a vaccine where modified BCG was being used. This was a trial which was again done. So this was the trial idea was initiated at AIMS, and since we wanted to take it countrywide, ICMR took the lead,
Mhm.
and we had 8 sites involved, 8 sites across the country where a tertiary center, a peripheral center, a district center, where they were all taken. So this trial is just concluding. In fact, end of this month, and we will
Okay.
soon have that data.
All right.
In addition, there have been trials in the country where prevention of relapse vaccine has been tried. Serum Institute of India was manufacturing the modified BCG, Kaufman's vaccine, and that was being tried as prevention of relapse vaccine. So a lot of, and in fact, the ICMR is probably considering the M72 molecule also, which showed about for slightly less than 50% protection. Again, an article published in New England Journal of Medicine. So there is a lot of effort to look at vaccines which can give us protection. So prevention of infection, like I said, would be the ideal. But yes, till such time we reach the ideal, we are trying our best to look at these vaccines which can give us protection from disease. Infection happens, but disease does not happen, and if treated, the patient should not relapse, because often past treatment, past tuberculosis can make things difficult for a patient. If he's not taken complete treatment, he can get a relapse, and then treating a relapse can be tricky, because sometimes the relapse may be due to a resistant organism. So it's difficult for the patient and difficult for the doctor as well to ensure complete treatment and cure. Yeah.
Okay. While the TB vaccine research goes on,
Yeah.
and we get the holy grail at the end, someday we should
Yeah.
be getting it.
Yeah.
What else can be done to prevent TB transmission? What are your insights on that,
So
please?
that's a wonderful question. And let me come back to what I've been saying, that the
Yes.
transmission is occurring from a patient who does not know that he has TB. So we sometimes ascribe a term called subclinical TB to such a patient who's asymptomatic, but he has TB and he's shedding the TB disease, shedding the TB bacteria in the environment. He's unaware, he's not gone to the system, he's not been put on treatment. So the first and the foremost thing I would say is people should become conscious about the basic pathology and pathogenesis of the disease, or how each and every one of us, now rich are not safe, or the poor are not safe.
Mm.
It is an airborne infection. For example, like I always talk about the polio detected in New York water supply. I mean, an advanced country who screens their sewage and water for any communicable disease, if they could detect. So
Yes.
this is something, things which are spread through air or spread through water, nobody is safe. So what we have to ensure is that a person himself is not diseased. If there are any symptoms, go get screened, diagnosed, treated, which is most important. Do not ignore your health, and the health system is here to help you with early diagnosis. Nobody will refuse, will turn you away. They will try and help you. So first is the subclinical TB needs to be diagnosed. So a lot of in the prevalence survey, they picked up a lot of these patients who were not symptomatic, but had, were diagnosed as
Mm.
TB. So first is this, that not to ignore your symptoms, health awareness, health education to the whole community. Everybody should feel free to come up with their symptoms and get diagnosed. Number two is taking care of nutrition. Like I said, the groups which are found in prevalence survey to have more disease
Yes.
were older age group. And the other day in a meeting, one of our very senior teachers was pointing out that in the older age group, sometimes it is difficult for them to reach the system. because of constraints relating to their transport, they need help and things like that. So we are trying to equip the system to reach such patients. But older age group, diabetics, people who are smokers, who are alcoholics may have higher chances. So all the more reason, get a regular screening, maybe an annual screening, right? Malnourished people should take care of their nutrition. So there was this ration study which got
Yes,
published
yes.
in Lancet, Dr.
Yeah.
Anurag Bhargav's study, and not only there's Dr. Hemant's study from NIRT, we have done a study in AIMS in Balabgarh, which is our outreach center. Dr. Rakesh has done, was leading the study, where we have given energy-dense nutrition supplement to our patients. So ration study has gotten published, which showed us that more than 30% patients were not really patients. The household contacts were benefited and did not progress to disease because there was nutrition given to them, calories as well as protein. So sometimes people think, calories alone is enough. What we need to also emphasize is proteins as a component of diet, and micronutrients as well need to be ensured in the diet. Those who are low BMI, like I said, should get screened for any such disease which may be incidental because of their poor BMI and their poor immune response, which the poor BMI leads to. And they should work towards improving their nutritional status. And there's a big push from several ends. We are also working to do active case finding and give nutrition to slum population. So we diagnose TB early, try to supplement their nutrition, and support them in all possible ways. So there is a drive from the health system side, but if the patient does take care of himself and his family, he's contributing to the community's welfare.
Right, very right. Urvashi, you have spoken about this earlier about bacteria becoming resistant and finding novel ways. So, but can you just summarize that once again, that what can be done to prevent TB bacteria from becoming resistant to the new TB drugs, and also for other types of diseases, the bacteria becoming resistant to somehow control or curb antimicrobial resistance, as we call it.
Yeah, right.
Can.
So let me first talk about TB, and I'll talk about the
Yes,
other bacteria. So I
yes,
think oversimplifying the problem, bacteria have to be harmful pathogenic bacteria, not the commensal and
yes.
the good bacteria in our
Mm, mm,
system,
mm,
need to be removed as early as possible. Why I say that is, the more the number of bacteria, for example, if a person gets infected with TB, ignores his health, there is a cavity formation in the lung, there is a number of bacteria go on increasing because there's replication of bacteria happening. The bacteria is smart, needs to survive. Now, the more the number of bacteria, the more are the chances that it will be drug resistant, because it goes on replicating, and every replication, so this is something I teach to my undergraduate students, every replication will bring in several mutations, because the replication can be
yes.
faulty and mutations will creep into the genome. Some of these mutations are capable of offering resistance to a drug. So the more the number of bacteria, we need, they will be more capable of generating drug resistance. So that is why I repeatedly am saying early diagnosis and early treatment are the crux of the problem. So we need to reach the system. The system needs to give the right treatment to us. When you talked about the other drugs, so so we use terms like primary MDR and acquired MDR. Primary MDR is when
Yes.
one gets infected with an MDR
With
organism,
anything.
and acquired MDR is when, while on treatment or in past treatment, this person gets resistance. So acquired resistance can often occur because of poor prescription. If a medical person or maybe an underqualified person, which we try not to, to restrict such practices, but
Yes.
is prescribing single drug, two drugs, drugs in low dosages. So the bacteria needs a certain amount of drug to kill it. If the drug is being prescribed at low dosages for the body, that is why we have, weight-based recommendation for drug regimen. So the right amount of drug, right combination of drug needs to be given. Only then the bacteria will get killed. If you're giving one drug, the bacteria which is resistant to that particular drug will now amplify, and will be stronger with resistance. So poor prescriptions, poor compliance on part of the patient. Sometimes the patients don't feel very good after taking an antibiotic, which can be possible due to a side effect of the antibiotic. So they need to approach the doctor, come back to the doctor. Okay, this drug is giving me these side effects. Can you suggest me something else? We often get, liver issues yeah, sometimes, but the doctors have an answer for that. They should come back to the doctor and not lose faith in the doctor, but also contribute by taking the prescribed regimen in the complete dosage for the complete
Yes.
duration. If they don't do that, they are only enhancing the drug resistance and making things worse for themselves. And like I said, they'll continue to disseminate the disease, making things difficult for the community. So all these, and like I addressed earlier, over-the-counter availability of antibiotics without prescriptions, and so on and so forth. I also mentioned about you know a wrong disposal of these antibiotics in landfills, and they are there in the water systems where a lot of bacteria can. So you've heard of this when the nomenclature New Delhi. So basically, what I'm trying to say is a lot of so this applies to other bacteria, especially. We have plasmids which carry bacterial resistance genes, which can transfer between bacteria. Not described in TB. TB, there is no horizontal gene transfer described, but in Escherichia coli, in other bacteria, horizontal gene transfer of plasmid which carry drug resistance genes is known. This can happen very easily in water bodies and sewages. So there was this New Delhi, the NDM1 was described and given the name New Delhi, which all of us objected, but it still can. So that was nothing but a plasmid, which is prevalent in the Asian continent, in Indian subcontinent, even in Pakistan. In China, we have something as KPC, and KPC has also been found in US because of the travel from here. So all this is where the One Health concept comes in. The misuse of antibiotics used for example, colistin, which is I've now moved away from TB. I'm answering your second question in other
Yes, yes,
bacteria.
yes.
So One Health concept ensure is trying to ensure misuse of antibiotics in other than humans. So our agriculture, we tend to use antibiotics. In fact, in a microbiologist community, we were having a big discussion about, these are available on Amazon. Antibiotics in big sacks are available online. And then misuse of antibiotics in poultry, in our in fact, this is a question I asked a team which came from the US, one of the universities. I asked them, are you able to take care of misuse of antibiotics in agriculture and animals? So they said no, they're not able to. So the AMR is not being generated by misuse in humans or by doctors alone. There is a bigger picture to it. So we need to address it in toto. And there is a lot of push globally toward in that direction.
Okay.
Yeah.
Thank you very much. And now we will end with your message for World TB Day, which is just very close. What is your message?
So I think I'll possibly be repeating what I said
Yes, maybe.
earlier. Um, so, despite our efforts to best diagnose and offer the best treatment, diagnose all kinds of drug resistances early, and offer the best of treatment, unless the patients and the community become aware that there is no stigma, there is why worry about anybody stigmatizing you? So I think the health education and knowledge about this being a completely treatable disease, if there's a delay in treatment, it may be difficult to treat the disease, or the treatment may be prolonged because the drug resistance may creep in. So I only want to convey to our people that if there are any symptoms, you should seek care, and do not hide behind your symptoms, or ascribe them to some simple ailment like post-viral or viral. Please seek diagnosis and seek treatment if required, and not just sit back. And those who have comorbidities, or those who have, say, older age group and they have such symptoms, please seek healthcare. Those who are undernourished, improve the your BMI by improving nutrition, the right nutrition. One more message that I don't think I mentioned was, there has been evidence So one reason that has not been covered a lot is higher burden of intestinal parasites in certain populations. For example, in our developing world, of course, possibly due to sources like soil or water, and also the personal hygienic techniques, intestinal helminths. There have been papers over the past 20 plus years which clearly show predispose a person to diseases like TB, even to diseases like HIV is of course encountered, and we are aware of the how that is acquired. But intestinal helminths can predispose. So, in during COVID also we ensured hygienic practices. So TB is nothing but a slow COVID. Again, that is another message. So, like we were afraid of COVID, oh, by inhaling we'll get TB. Please be aware that you can get TB by inhaling. Only difference is TB progresses slowly and COVID was progressing faster. So we must, this is talking about parasites. We must adopt hygiene in all our ways. Hygienic air or environment, air pollution. We know is a deterrent. We should take care of ingesting hygienic water, food, and those who have parasitosis or who have symptoms of parasite should again seek healthcare and get treated. Even in China, there is a lot of intestinal helminth burden, which possibly can be predisposing these populations. So if you see, the high burden countries are all developing countries. So one is, of course, there, like they said, once industrial revolution came in, when the TB in the West got the problem of TB in the West got solved, which I'm sure we will also reach. But what is the crux of all these? There is undernutrition, there is high parasitic load. These are the things that the patients themselves can take care of. And the more they're aware, the more they will approach the healthcare and will be taken care of. So I think so I would urge more and more people to approach the healthcare system, seek answers, and practice healthy habits, clean habits for their own health and their family's health. Thank you.
Thank you very much, Urvashi, for clarifying so many of our doubts and for simplifying for our listeners the complexities of scientific tools for diagnosing TB. Friends, we were listening to Dr. Urvashi Singh, professor in charge of tuberculosis division of the Department of Microbiology, All India Institute of Medical Sciences, New Delhi. Thank you very much, ma'am.
Thank you very much. Thank you, all of you.
Thank you.